So, good afternoon, everyone, and I welcome all who are present to our instruction course. I'm very happy and proud that I have my mentor with me as a co-instructor, and as he has other commitments, he would like to finish his talk, and uh, it's over to you, sir. You can start.
Thank you, Santosh. Thank you, Santosh, for having me in this session. Foreign body on, in and around the eye, catch them early. And to detect foreign body, you have to do the following things depending on the eye: ultrasound biomicroscopy, plain X-ray, CT scan, MRI, and electrophysiological tests. So you need a strategic thinking in ocular trauma, particularly to manage intraocular foreign body. And strategic thinking is individualized approach. Think again and again what is the most suitable line of management for the given patient. So when you have a patient, you should have a plan, and that's what we have to make a logarithm what you will do, and that's what is done before the surgery. So the systematic approach must have its basis in the scientific literature and genuine personal experience and no dogma involved. And I fully agree with Ferenc Kuhn that the surgeon must not act on a trial and error basis, but according to this plan. So you have a game plan like a soccer, and if the things change, then accordingly you can decide. And this is what I mentioned in the previous course. My philosophy: eyes with no PL vision should also undergo primary repair, even though as though the eye may get when the anatomic success is estimated to be less than 1%. And optimal timing for a posterior segment surgery: immediate vitrectomy is indicated for post-traumatic endophthalmitis or intraocular foreign body with high risk of infection. And the best timing of vitrectomy for severe mechanical ocular trauma is nowadays we have come to a conclusion, not the 7 to 14 days, 6 days. So, in a case of an intraocular foreign body, we have a 34-year-old male with a penetrating ocular trauma with pellet in the right eye who had undergone primary corneal repair. And with the same philosophy, Dr. Tariq is here from Srinagar, who we now decided we'll do the wound repair and within 6 days do the second surgery, which you'll see now. This is the within 6 days you saw the cataract happening. There's a corneal suture. The B scan done, ultrasound showed the pellet had gone into the back of the eye. And here you see this is a surgery done. Cataract was done by Dr. Kavita Rao, and here she does the lens aspiration because it was a 34-year young person who had injury. You can see the corneal wound there in situ. So the corneal suturing also is important, and then she places the intraocular lens. And then following that, I proceed with the 3-port pars plana vitrectomy, and you can see there is a submacular hemorrhage. So I clear the vitreous hemorrhage, and many times the PVD is not there, and also do a subretinal drainage, and then do a endo laser around the breaks created. And this is a post-operative picture. The eye was quiet, fundus is seen, and the vision was counting finger 1 meter because of the corneal astigmatism. And we have done vitrectomy for about 777 pellet ocular injury, because we could have, since we had follow-up of them, we presented this, but totally more than 1,000 injuries that happened, and that was the problem in Kashmir. And you can see this is a fakey eye. I do a 3-port pars plana entry, thanks to Dr. Tariq and the team. They were wonderful. You can see the entire vitreous hemorrhage is cleared, and there is a traumatic retinal detachment nasally. So we can all barricade that place with the endo laser, and there was subretinal hemorrhage. We can leave it as it is because it's away from the center, that's macula. So this is what we are barricading after doing the endo laser and doing a fluid air exchange, leaving with gas. And with the 6/6 vision, usually you get good vision. And thanks to Dr. Prasanna Venkatesh from Trichy. He made a graphic design for us to see how we have designed a specific scleral incision to remove the foreign body. And the one thing we did in pellet is a light one. So when the pellet was engulfed in the vitreous hemorrhage, instead of removing the entire vitreous, we do the removal of the vitreous hemorrhage around the foreign body. But when the foreign body is within the pellet, we make a 11 to 1 scleral incision. First the conjunctival incision, then the scleral incision, and use the claw forceps designed by Manish Bapaye and myself, and then enter and then grasp the foreign body within the vitreous hemorrhage and then remove it as you see here. And this is where it's the least traumatic to the eye. So this is the claw forceps, which is a novel intraocular foreign body forceps, which we published in IJO, which is this is the IJO publication. And then here you see another eye with the three-port pars plana vitrectomy for the pellet removal. So we clear the vitreous hemorrhage, and then we look for the pellet. You can see the place where you see a subretinal hemorrhage, which is actually the place it was impacted, and the pellet has fallen down in the 6 o'clock meridian. So once you see the pellet within the vitreous hemorrhage, you don't do a total vitrectomy, so that the idea is pellet not to fall on the surface of the retina, because when you're using the forceps, there's a possibility you can damage the retina. So here the pellet is grasped by the 11 to 1 incision through the forceps, and then the pellet is removed. So we have done that in the phakic eye as well as in the aphakic eye. So this is since it was a fresh injury, there is no PVD. It takes time for to induce PVD, so that's why you need experience to manage the uh, which is hemorrhage and a pellet injury like this. And this is the forceps being using to grasp the pellet from within the vitreous hemorrhage. It's a phakic eye, and after clearing some amount of vitreous, and then you can see the vitreous which is attached is teased with the light pipe, and then the intraocular pellet is removed. There you can see the pellet is now removed, and there is some tinge of blood on the surface of the lens, but you can close the scleral wound and the conjunctival wound and proceed with the vitreoretinal surgery, and make sure that if endo laser is required, do the endo laser. And if the vitreous hemorrhage had the pellet, there is no need for any trauma because there is no retinal injury. Sometimes the pellets go through and through the scleral wound, and this is the photograph while the pellet is being removed. And this is another eye by removing the, and this is a pars plana vitrectomy, removing the foreign body, and also the reattaching the retina. So this is the place again, the pellet had gone through and through. So when the pellet has gone to the orbit, into the orbital fat, you can do a barricade laser like this and need not have to remove the pellet because it's not within the eye. So this is another three-port pars plana vitrectomy for removing. So this was the thing. I went 5 months to Kashmir to remove the pellets, and thanks to Dr. Tariq for having me there. So the New York Times covered as an epidemic of dead eyes in Kashmir as India uses pellet guns on protesters. We also presented in the RO, and it was there in the RO IOVS impact of 7.7 pellet gun in ocular injuries in Kashmir. And later, the full text was published in the Indian Journal of Ophthalmology, a series of 777 pellet gun ocular injuries over a 4-month period in Kashmir, which is the highest in the world. And there was I made an editorial on an ophthalmology response to the humanitarian crisis in Kashmir. So this is another eye with a bullet injury. You can see the likely it was a toy bullet, but I think we have to teach the children and maybe educate the parents not to have the toy gun or the real gun next to the children. And you can see this small 5-year-old brother took the gun and shot in a close range to the sister, which is 6-year-old, and playing. And you can see this aluminum pellet bullet went into the eye. If it was a real bullet, the child would have died. So we had another bullet injury from Pune. I think sometimes the whole eye is gone, and luckily the patient got saved. So you can see the aluminum bullet is being removed through the corneal wound, and then I do the corneal suturing. And there is a last for glass foreign body. So here glass is stuck in the angle, and I have to be extremely careful to avoid hemorrhage happening. So you have to be meticulous in handling the glass foreign body. So this is again another article by Ferenc Kuhn on the trauma. The surgeon dealing with mass casualties must perform as many operations a day as possible, but should always be aware that heroics is no substitute for quality. The two surgeons who oversaw were myself and Tariq. And this Dr. Peter Wiedemann has also written how to be a good surgeon by having a passion, patience, psych, participation, planning, posting, practice, and precision until perfection is close. And sometimes you need a prayer. That's he has quoted me. So I thank my team for this. Thank you very much, Santosh, for having me here.
Thank you, sir. It is always inspiring to listen to you and come across these kind of cases where you can always tell yourself nothing is not operable. So, any question from the audience? Or else we'll go for the next one.
Want to ask something? Yeah. Yes. Yeah, that is why I don't go make the pellet fall on the surface. But there are some injuries where the foreign body may be on the retina. So I usually use methyl cellulose to lift the foreign body. So little lift is enough so that you can have the, without touching, you can grasp it. And yeah, so I made it, the reason is foreign body forceps is also 18 gauge, and better to have a what do you call a luxurious entry so that it doesn't get caught when you're removing. Because otherwise, you make a smaller sclerotomy, there's a possibility of the foreign body getting stuck. No, it should be almost 1 millimeter on either side of the foreign body. That much enlargement has to be done. So if it is a very large foreign body, and in case it is a phakic eye, you can remove transpupillary to transcorneal. But if it is like this, I think 5 to 7 millimeters I make. Right. So instead of extending, I made a separate incision at 11 to 1. So the 3 ports are there, and this is separately made, and then the wound toileting is done and the suture is done so that you don't get a dialysis because of the sclerotomy.
Is it posterior to the sclerotomy, sir? Is it?
No, same path 3.5, but I make it in 11 to 1, so go straight and remove it.
Another point is if the foreign body is outside the eye, you may
leave it.
Leave it
Because you don't have to.
That is a case in my presentation also where
okay.
I have to. Thank you, sir.
Thank you.
I think you can photograph
with you.
With we are leaving. If you come back, we can have photograph at the end.
I'll have one picture and go because I don't know. That's the other end. I have to go.
So you can join us, whoever the speakers have. So you can. So please sit down. We'll have a photograph and then you can stand.
Come on, can come.
All of you can sit down. Yeah.
All 4 of us?
Yes.
You can sit here together.
Thank you.
Thank you. Yeah. Sit here. No, so that you accompany it. Thank you, Santosh. Carry on. Maybe we can introduce Santosh to do the next talk. Thank you.
So we can start with the first talk, that is mine. So this okay. So good afternoon, everyone. Thank you for being here. First of all, I'd like to thank all the audience. So approach to ocular foreign bodies. Before that, a little bit of theory, that is classification of ocular trauma can be mechanical or non-mechanical, and foreign body is included in the mechanical groove, which also includes closed globe, open globe, penetrating and perforating injuries. So all of us know about the Birmingham eye trauma terminology system, and we need to follow it. And I just want to emphasize the foreign body is in the open glove category, and the globe injuries is it's classified according to the type, grade, RAPD or zone, whether it is a closed or open globe injury. And the ocular trauma score helps us to prognosticate the injury, and it gives us a rough idea of the outcome. So the evaluation starts with thorough history taking, visual acuity, pupillary reaction, ocular motility. The eyeball needs to be seen as a whole, whether it's soft or digitally normal or of high intraocular pressure. Lid, adnexa, cornea, sclera, AC, lens need to be meticulously evaluated. Gonioscopy, if possible, can be done, and fundus examination, whenever possible, should be done. But the most important thing is you need to radiologically evaluate the case to have proper management plan, which includes both anti-segment and posterior-segment photography when possible, X-ray, B-scan, CT scan, MRI, UBM, ASOCT, and sometimes EIG. X-ray is still a valuable tool if you are working in a remote center and any other mode of investigation, radiological investigation is not available, where you can directly tell that a foreign body is present or not just doing an X-ray. Except for wood or glass, all metallic foreign bodies, if present, is detected by X-ray. So you need to do it. And B-scan tells us about the type of foreign body most of the time, but most importantly, it has not to be performed in an open globe injury with extrusion of ocular contents. Better to do it post surgery. CT scan can detect the number, size, shape, and location of a foreign body and its relation to the ocular codes. In a wound, it gives rise to a low attenuated radiological contrast with no artifact, plastic moderate, glass high, and metal very high attenuation, and sometimes a scatter. MRI, where is most importantly need to be done in other non-metallic things, particularly if you suspect glass or organic foreign body, but it is contraindicated if you are suspecting a metallic foreign body. UBM helps us to see the angle structures and usually avoided in open globe injuries. It's not moving. Okay. ASOCT is a non-contact method, and you can see the structures that is anterior to the iris, but those are lying behind the iris might be missed. ERG is particularly helpful if you are suspecting a metallic foreign body which was not detected earlier, and siderosis is being produced, and it prognosticates the case most of the time. So the management of foreign body are basically to prevent further ocular trauma to the eye and psychological trauma to the patient and the family, and to minimize the risk of infection and legal problem. Objectives of repair are many, and most important objective of repair is integrity of the glove. The foreign body can be on the cornea, in the lid, it can be in the AC, in the lens, or in the vitreous cavity, or inside the retina, and sometimes orbital too. Why the foreign body needs to be removed? There are innumerable number of reasons why the foreign body needs to be removed, and most important is to prevent infection and loss of the eye. Foreign body in the AC is going to be dealt with by my colleague Dr. Arvind, Intralenticular foreign bodies need to be approached cautiously, and most important, only one point is hydrodissection need to be avoided, and it may enhance the capsule, and also sometimes it may cause fall of the foreign body into the vitreous cavity. This angle foreign body also will be dealt with Dr. Arvind. Posterior foreign bodies. Posterior segment foreign bodies can be in the vitreous cavity, intraretinal, subretinal, or in the scleral, between the chora and the sclera. And if it is extruded outside, it can be orbital too. So here is a unusual foreign body, a matchstick, which is impacted near the pars plana in an 11-year-old boy, and it was approached from the vitreous cavity. The lens was clear, so you have to be very careful while removing the foreign body, as the length of the foreign body is around 6 to 7 millimeter, and I have to negotiate the foreign body in such a way that it has to come out through the scleral wound without injuring the lens. Magnetic foreign body is most of the time easy for us, because it is most of the time can be dealt with a magnet, but you have to really locate the foreign body. Dr. Umesh is going to deal the posterior segment foreign bodies in detail. I'm just trying to show few cases where there is a clue. Yes, it is a larger one. So as we are discussing, needed a sclerocorneal tunnel to be removed, and associated retinal detachment need to be dealt with it. Sometimes the foreign body had produced a choroidal rupture along with the vitreous hemorrhage or a retinal detachment. So a foreign body which has produced a choroidal rupture, but the integrity of the globe is still there, you don't need to do anything extra apart from removing the foreign body in the usual manner we remove, and many times you need to laser the area so that the retina, further chance of retinal detachment post-operatively is avoided. This is the site of choroidal rupture, and that's why there is a large bleed which is not cutting into the aspiration tip of the cutter, and the metallic foreign body which is falling on the disc is approached with a magnet, and it is removed. This foreign body, which was actually, we thought it is subretinal, as it is still on the intraoperatively, was felt hard while I was touching and looking white, but could not be stressed in spite of best of my efforts. And when I injected, after failing to remove the foreign body, you can see the silicone oil is coming out through the other scleral wound. So I have to first maintain the integrity of the globe, as it was collapsing repeatedly in spite of repeated intraocular air injection. So finally, after struggling for almost 20 to 30 minutes, I found the globe rupture area, scleral rupture area, just below the lateral rectus muscle, and you have to suture it with much struggle, because the wound is placed in such a way it was not possible for me to visualize it properly, and the glove is too soft. It was already vitrectomized, so it is causing further problem, and finally I could suture the sclera with 60 Weichel sutures. So this foreign body could not be retrieved, as Dr. Natarajan was telling, and finally the globe integrity is maintained. You can see the entry wound here, and the exit wound was behind the lateral rectus muscle. And the globe finally formed, and the foreign body was left as such, which was orbital now. So this is again a medical legal as well as a medical question, but if it is definitely orbital and not going to cause any reaction, it can be left as such. So this is the final foreign body, is the orbital one, which was seen in a 41-year-old male while he was driving a motorcycle and drove into a tree branch. This is the pre-op and post-op picture, and this is the how the foreign body was removed. It was done in a multicentric hospital because the foreign body traversed across the nose transnasally into the opposite maxilla, but luckily no vital structures were injured, and the CT scan helped us to localize the foreign body, and it required me a bone nibbler at a multicentric center to remove the foreign body. And this is the largest foreign body we came across on science, intraorbital foreign body on literature, and it is almost going to be published, accepted for publication. So the take-home message is ocular and orbital trauma with impacted foreign body has to be treated as emergencies and need to be attended on the same day. Meticulous history taking and radiological evaluation is of paramount importance for proper management plan. And removal of the foreign body involving subspecialty approach yields the best result, and medical legal aspects should always be kept in mind. It may cause problem later on, and very rarely it can be left alone. Thank you very much. Any questions can be addressed, otherwise we'll go for the next talk.
I have a question, Dr. Santosh.
Yes.
The large foreign body that you moved.
Yes.
So, what was the status of the nasal bone and the lacrimal apparatus?
Yes, the nasal septum was breached, lacrimal apparatus was intact, and there was epistaxis at the time of presentation, and we operated next day morning, and there were epistaxis was by the time was stopped. We operated the patient in presence of a ENT and neurosurgeon, and maxillofacial surgeon was also on call. So we expected might be there will be some problem during surgery or post-operatively, but luckily the operation went well, and we have to thoroughly clean the nasal cavity with and also put packs to stabilize the nasal septum as well as to prevent further epistaxis. And luckily no bony injury to the base of the skull was there, and all the intracranial structures were intact. Yes, we sent, but it yielded a negative culture. But we covered the patient with both systemic cephalosporin, metronidazole, and oral antifungals. Thank you.
So, now we have Dr. Umesh Bera, who is a consultant at LV Prasad Eye Institute. He's a retina specialist and does a lot of innovative work. And his surgeries are something to be first for when he operates on the post-resection of the eye. So, he will be taking on the approach to post-resection of the body.
Thank you, Samir.
चलेगा.
Okay, anyway, Santosh discussed a little bit about the general management of foreign body in the eye. I'll limit myself to the posterior segment approach. So we proceed with the management by identifying the foreign body, and we generally plan the surgery beforehand because there may be a lot of surprises intraoperative, and we'll briefly touch upon some of the techniques that we commonly employ. So the common imaging modality that is used to detect the foreign body is B-scan because it's available bedside, and this is the investigative modality where you can image both radio opaque and radio lucent foreign bodies. But at times we may face false negative results if the foreign body is too small or is anteriorly located. Gas bubbles, on the other hand, which may be uh, lodged along with the foreign body inside the vitreous cavity, may throw up as high reflective echoes and may mimic a metallic foreign body. So they are the false positive results. But no matter what, we do not depend on B scan for the size of the foreign body. So while metallic foreign bodies are easy to pick up because of their very high reflectivity, at times glass foreign bodies may be missed because unless we direct the sound energy against the surface of the glass, we may not find an echo being produced. So similarly, for imaging organic foreign bodies, B scan scores over a CT scan because on CT scan they may be hypodense and may be missed. And as we just discussed, air bubbles, if they are present inside, just the changing position of the head may confirm the diagnosis. CT scan is believed to be gold standard in imaging such foreign bodies which are intraocular because they can exactly pinpoint the location and the size of the foreign body. At times, we can have a 3D reconstruction of the tissue. At times, if there are multiple, B scan may not image it properly. So multiple foreign bodies can be imaged easily on CT scan. And if the foreign bodies are small, with very small slices of the CT scan, we can generally image them. The limitation being that the wood and plastics may be at times missed in CT scan. Ultrasound biomicroscopy is very, very useful in those foreign bodies which are anterior, and all those principles of ultrasound B scan apply here. Timing of surgery is crucial in intraocularly lodged foreign bodies because they have a potential to infect the globe and lead to traumatic endophthalmitis. Generally, these surgeries are taken up on the same day on an emergency basis to prevent the risk of endophthalmitis, or in a few days' time to reduce the risk of lens-induced glaucoma and corneal decompensation. At times, if the foreign body is lodged inside for a longer period of time, toxicity is also another issue. But at times in blast injuries where infection risks are less, or in injuries where we have glasses inside the ocular tissue, we may buy some time before the patient is ready for the surgery, and that window time should not exceed 7 or 14 days. So if we look at a case example, generally the foreign bodies which penetrate through the cornea, they leave behind a track which corresponds to the iris trauma and the corresponding lens injury. So these eyes are generally imaged both with B scan and CT scan to locate the foreign body. And if we look at the surgical approach, generally to form the globe first, we close the entry wound and proceed with the vitrectomy. If the lens is injured, the lens has to be removed. While fashioning the sclerotomies, the point at which we may anticipate extension of the sclerotomy, we may have to do a peritomy to proceed with. So this is the dominant side of the surgeon. That's why the sclerotomy, peritomy is chosen on this particular sclerotomy. So as we proceed, generally the media is cleared, meaning if any lens matter is there to be removed, it's aspirated depending on the age of the patient, or with a phacopragmentum, you can remove the lens. In this particular case, the foreign body is lodged on the surface of the retina. In these cases, it's quite important to induce the PVD. So while we induce the PVD, the foreign body in itself dislodges from the impact site, and that minimizes the retinal injury. So these eyes are generally prone to retinal detachments. So to minimize the retinal trauma, the foreign body is gently teased out of the adjacents at the impact site. And if it is a metallic foreign body magnets are used to levitate to the anterior part and removed. So how do we decide what uh, the ideal route or the mode of foreign body removal? It all depends on the type of foreign body, size, and the location of foreign body. And at times, if we wish to save the lens, we may have to change our plans. So generally, metallic foreign bodies are common, and no matter what it is inside the foreign body, if it is shining and looking metallic, you should try with your magnets first. If it fails, then you may resort to forceps deliveries. The ones which are smaller, which could be removed through a very small sclerotomy, uh, the foreign bodies which have a smaller diameter of 4 millimeter or less, they can be removed through the sclerotomy site, or else the larger ones could be removed through a sclerocorneal tunnel. Here, I would like to stress that there is always a risk of hypotony, persistent hypotony, or even phthisis in these eyes if you extend this sclerotomy uh, to almost a quadrant. So these heroic surgeries are generally discouraged. Instead, you can do a sclerocorneal tunnel with a handset technique. You can remove the foreign body through the anterior route. So location of foreign body, if it is anterior, again, we have to tease it out of the tissue, and the foreign body removal is through the anterior route again. Foreign body which are lodged subretinally, we may have to do a retinotomy and remove them. One of the aspects of preventing the macula and the disc being injured by the foreign body is to have a bubble of PFCL on the posterior pole while dealing with the peripheral foreign bodies while they are dislodged. This is a small video which shows the foreign body being lodged anteriorly. To improve the visibility of the impact site, we may have to do a sector iridectomy, and the foreign body, depending on its size, either it could be removed through the pars plana or the limbal route. Here, we use a handshake technique, and with the left hand, the corneal clear corneal tunnel is made to remove the foreign body with a handshake technique. The number of forceps that are available, which you can employ intraoperative, which we'll be just discussing. Yeah, this I think this is the safer way to remove it. At times, if your entry wound is large enough, you can remove the foreign body through the entry wound itself without the need of fashioning a sclerocorneal tunnel. There are various magnets available in the market in various sizes, 16, 18, 20, or 23 gauge of magnets. They have a rear end which is more magnetic than the tip. So the tip is used to engage it, and once you get it onto the sclerotomy site, you can change the polarity of the foreign body magnet and use more of traction to remove the foreign body. At times, you may employ forceps. If it is a non-metallic foreign body, we have max grip forceps or claw forceps. If you don't have anything, you may use a soft tip cannula, mount it over the extrusion cannula, and you can use the suction force to get the foreign body to the exit site. There are various other techniques which are described in the literature. I have never tried them, but such suture techniques are also used to prevent breakage of the foreign bodies intraocularly. Claw forceps, Dr. Natarajan just showed you how best he could use it to remove the pellets from the eye. The other forceps that are also available in the market are the alligator forceps, which can open like all your DCR, DCT surgeries, and they can grasp the foreign body well. So the simple forceps, like your Eckart's forceps, can also be used to grip it and getting it out. Previously, we used to use large magnets, but they are nearly redundant now. We have a role of scleral buckling to prevent the sclerotomy related complications in these eyes. It can be planned before initiating the surgery by placing a 360-degree encircling band, and that's quite useful in uh, uh, the surgeons who are beginning their careers. Antibiotics are a must in such situations. Systemic antibiotics, intraocular antibiotics to prevent endophthalmitis, and perioperative antibiotics should be used to prevent the infection that is very, very likely in such eyes. Thank you so much.
Thank you, Miss. Just one or two questions. What is the upper limit of the scleral wound you want to make to remove a foreign body of larger size, or else you switch over to sclerocorneal tunnel?
Yeah, I don't go beyond 4 millimeters. That's where I restrict myself. If it is more than 4, then I choose the anterior route through the sclerocorneal tunnel. Even if I have to sacrifice the lens, also I do that because I don't want a soft eye post op it.
So, if yes, thank you. And the second question is, I saw you are doing the clear corneal entry wound in your non-dominant hand. So, is it better that if you are suspecting a larger foreign body which needs to be removed through the sclerocorneal tunnel, can you design a sclerocorneal tunnel before approaching the foreign body?
Yeah, in this particular case, we didn't anticipate it to be so large. That's why I had to use my non-dominant hand. But it's quite easy to enter clear corneal with your keratoon.
Sometimes it becomes a little difficult with your non-dominant hand, so better to plan, I feel.
Yeah.
Any other question from the audience or the other panel, or else we'll go for the next. Thank you, Miss. Very elaborately and very specific point wise you have described approach to the posterior segment foreign body. Now I'll request Dr. Samir, who has replaced Debjyoti, to present the approach to orbital foreign bodies. Over to Samir.
Good afternoon, everybody. As you have already heard about intraocular foreign bodies, the approach to posterior segment foreign bodies, and a lot of videos. So what I would deal with is adnexal and orbital foreign bodies, and in my talk I'll just give you the basics of an management of orbital foreign bodies and then take you through a series of cases in different phases of its evolution to give you an impression about how does and what is the effect of a foreign body inside the orbit. Now, I have no financial disclosures, and so orbital foreign bodies are very rare, and it accounts to only 3 to 16% of cases in ophthalmic trauma, mostly associated with penetrating injuries, and in Indian scenario, it's road traffic accidents and domestic falls, the most common ones. 25 to 60% of intraorbital foreign bodies are actually missed during the initial presentation. So that is a very alarming sign whenever when we deal with such type of cases, and they remain asymptomatic for pretty long period. So what is important that you should have a high index of suspicion following any orbital trauma. If there is a persistent inflammation in the periorbital area, if there is a sudden onset of vision loss or any other orbital complications like an orbital abscess, or if you find any direct visualization of a foreign body part or a palpable mass in the periorbital area following in periorbital trauma, we should always suspect a retention of a intraorbital foreign body. Now, the clinical manifestations are very well described in literature. So, what I have pulled out from my cases is a series of patients. What you see describing each and every of the clinical presentations. So, these are the patients where you have an externally visible foreign body penetrating into the orbit. This is something presenting as a complication after a certain period of time with an abscess. This is something, a complication arising out of a retained foreign body causing massive proptosis and exposure keratopathy. This is a ptosis that comes after injury with foreign body. This is something a patient presents to us with smoldering anti-segment inflammation pretty long after the initial insult was done, and then finally a patient with ptosis and retained foreign body. And the details of all these cases will be discussing shortly in my subsequent slides. Now, orbital foreign body can be classified as organic, as we all know, wood being the most common one. Inorganic can be metallic or non-metallic. The important point is wood have got a very rough surface. They are porous, so they do imbibe fluid and water in the when they are within the orbit. So they provide a substrate for rich bacterial flora to grow that causes rapid growth of organism and rapid onset of inflammation. They are more toxic and are easily missed on imaging. Whereas metallic foreign bodies or inorganic foreign bodies, unless they are contaminated, they do not provide any such flora for the natural growth of organisms. So the onset of inflammation is very slow, though some of the metallic foreign bodies can be toxic like lead, iron and copper, but these foreign bodies from the orbit aspect of view have got very minimal role in inducing an inflammation. So these can be easily identified on imaging. The management protocol are very clearly laid in literature. So what I have done is simplified this for your understanding. So detailed history of the injury, the mode of accident, the site of injury need to be taken from the patient, where he was working, how did the injury happen, and what kind of foreign body is the patient describing. It's very, very important. Sometimes the patient will say a stone had hit into my eye. Sometimes they'll say a stick has entered into my eye. So that will give you an initial impression about what is the nature of the foreign body. Then finally, the next point is an anti-tetanus prophylaxis and a primary wound care that is more important. Broad spectrum antibiotics need to be started immediately. The role of antifungals and steroids are still controversial, which I'll be discussing in my last slide. Imaging, CT scan is the gold standard. So legally, X-rays do stand as an imaging modality of choice at places where you do not have a CT scan facility, just to save your skin. But CT scan is the modality of choice for any other foreign body, be it metallic, be it organic. Now, MRI is CT scan helps us in detecting the size of the foreign body, the location of the foreign body, the type of foreign body, and any other associated injuries associated with it, like a orbital fracture. Now, the two modes of approach to management. One is a conservative management. It is because it only indicated in cases when the patients are asymptomatic, the patient have an inorganic foreign body, posteriorly located foreign body which are very close to the optic nerve or the orbital apex, where you feel that if you tend to remove such a foreign body, you are going to do more of collateral damage than benefit. In those conditions, conservative approach is what is advised. Surgical removal is advised when the patient has got symptoms because of a retained foreign body, orbital complications, all organic foreign body has to be removed. Anteriorly located when the ease of removal is there and there is very less chance of doing a collateral damage. Contaminated inorganic foreign bodies, when you have taken a proper history, you will know that even if a metallic foreign body goes into eye, it may be from a grease coated metallic foreign body or from a grass that has gone inside along with the metallic foreign body. In those conditions, contaminated inorganic foreign bodies need to be removed. Lead, copper, and iron traditionally for intraocular foreign body, yes, but for orbit point of view, research says that there is no impact or the onset of inflammation is very, very minimal. So unless it is very, very symptomatic, it can be left as such. Impending threat to vital structures. What I mean that if the foreign body is impinging on the optic nerve, causing visual disturbances, or it is at a structure which will cause further damage to a blood vessel, in those conditions, surgical removal is mandated. Now, CT scan is very, very important. So what I have done is to show you different types of foreign bodies and their CT characteristics. So this is a foreign body which you see in the superlateral orbit, just located beneath the zygoma, and you can see that it's a hyperdense foreign body with radiating streaks, just like a metallic scene. So this is very, very classical of a metallic foreign body, and you should not miss this on the CT scan. Now this is the coronal cut. Now a similar foreign body, you can see a hypodense region resembling almost that of a air, resembling that of the sinuses, is traversing from the anterior part into the through the supraorbital fissure into the brain. So this is a long wooden foreign body, and it can only be detected with a CT scan. So this is a fresh wound, so that for that reason this appears to be hypodense. Now similarly in this coronal section, you can find, compared to the right eye, right side of the orbit, the left eye has got a similar hyperdense area with a small hypodense area here in the left side in the inframedial orbit. This is suggestive of a foreign body also. Now this is in the transverse section. You can see the foreign body is traversing in the inferior orbit, causing a fracture with prolapse of the orbital contents. Here you can see a hyperdense foreign body, but not as a metallic scene. So this is considered to be a glass foreign body. And finally, in this 3D reconstruction, you can find a small foreign body, hyperdense, just stuck into the supraorbital rim. So the importance of this slide is that whenever you're ordering for a CT scan, you have to look through the serial images of both axial, coronal, and the sagittal cuts, as well as the 3D reconstruction images. Now, CT appearances of wooden foreign body, if it is an acute injury, that will appear as hypodense, which will appear as dark or black in color. Whereas if it is subacute, it imbibes water, becomes dense, so it will become isodense. Whereas in chronic stages, the density is more and it will appear as hyperdense, as seen in this picture here. Now green wound, so now if it is an injury with a fresh green wood, it will appear hyperdense, but if it is a dry wood, it will appear as hypodense. Now, CT versus MRI is a controversial subject, but here's the role of MRI is to differentiate whenever there is an indistinct appearance on the CT scan. Like in this patient, you can see a lot of orbital inflammation in the inferior orbit, which we cannot make out if there is a foreign body or an abscess cavity. But the same patient, when a MRI was done in the T2 weighted images, you can clearly see a hyperdense area with a hyperdense substance here that rules out a foreign body. It can be, it was clear enough from the history that it was not a metallic foreign body, so MRI was done, and this is in the sagittal cuts. So cross-sectional area is important. So MRI can detect smaller foreign bodies compared to CT scan. Now, surgical removal have got the principles like minimal damage and maximal exposure. Surgical incision, any of the roots can be taken up, but ideally it should be taken up from the original entry wound so that the minimal damage is done to the collateral structures. Never push the foreign body. Try to hold it tight and bring out through a gentle pull so that all the adhesions of the resistance is overcome. Complete removal is very, very important along with the necrotic tissues, and always you have to send this tissue or the foreign body for microbiology culture. Intraoperative irrigation with antibiotic saline need to be done, and a close follow-up is mandatory. Now with this, I come to the case scenarios. Now this is a 26 years male who sustained this injury while working in a garden. Now here the globe was fixed, and it was any attempted movement was causing pain for this patient. So this the reason also could not be recorded, only that the patient had a PL positive. Now, when you do the CT scan, you can see that the foreign body appears to be penetrating the globe. And the coronal cut, you can see that there is a fracture here. The foreign body is just lodged here. And then if you go to the sagittal cut, you can see a large floor fracture that has happened because of this penetrated foreign body, and the globe and the orbital contents has prolapsed into the maxillary sinus. So in this condition, a transconjunctival orbitotomy was done, the foreign body was removed, and the fracture was repaired, and this is what is the final outcome. Now this is a second example, a similar example where the foreign body was there, but it was not as externally visible as the first case. So here the foreign body has gone had traversed into the brain through the supraorbital fissure, and this foreign body was because of the intracranial penetration, there was a risk of meningitis, so it needed urgent removal with the help of a neurosurgeon. And this is what we removed this foreign body. Almost about 8 millimeter foreign body was removed from the brain to prevent meningitis, and this microbiology grew gram-negative organism for which it was appropriately treated. Now, this is how it was after the surgery. The vision could not be impaired because the patient was already PL positive. Major of the optic nerve and other vital structures were damaged, but still we could save the life of this patient. Now, this is the third case scenario where you have a hidden foreign body, organic in nature, delayed presentation almost about a month after the injury. So the patient had an injury with a foreign body. The initial lacerated wound was closed elsewhere. The patient presented to us after a period of 1 month with a diagnosis of acute dacrocystitis, for which he was referred to us for doing a DCR surgery. So on doing a CT scan, you can see that there is a hyperdense area here with the central hyperdense area, which led us to a suspicion that it could be a foreign body. And then when we palpated, we just could palpate a small nodular irregularity of the inframedial orbit. On surgery, when we opened up through the entry wound, we found out this foreign body, which was lodged deep inside the orbit, and it came out successfully. So and this is on the treatment after the treatment was done. So you can see that the wound has healed well, but there is some amount of aponeurotic ptosis which needs to be repaired later on. There is a fourth case scenario where you have a hidden foreign body, inorganic nature, delayed presentation, but symptomatic. So here what happens is 37-year-old male who had an injury with the iron foreign body while he was cutting rods, and that was injury to the superior orbit, and he was asymptomatic for almost 12 years. Now he developed sudden onset of intermittent pain over the superior middle orbit for 3 days, and this symptom was on and off for the past 1 year. So he had good vision and the fundus was normal. So when we palpated, there was a tender palpable nodule over the supramiddle orbit in the left brow. And when we did a CT scan, you can see that there's a hyperdense lesion in the supramiddle orbit. And this is what I was saying, the metallic seen over the supramiddle orbit. And you can see here in the coronal cut, the foreign body was just stuck into the bone of the supraorbital rim. So when you took out this was a metallic foreign body with surrounding fibrosis. And once it was removed, the patient had absolutely, which was symptom free. And this is my last case, which I want to reiterate that whenever you are in practice, you will have come across cases where the primary foreign body would have been removed by the primary treating surgeon or the surgeon who has taken up the cases. So here is a 20-year-old, I'll just finish the last case. So she was a 20-year-old female who had a fall from a bicycle and had a foreign body inserted into eye. The foreign body was removed. It was a bamboo stick at the primary hospital, and then he was started with IV antibiotics and NSAIDs. But over a period of about 2 months, he developed sudden onset of, gradual onset of proptosis with exposure keratopathy and was referred to us for evisceration. Now, the left eye had no PL, and because of this exposure keratopathy, it was merely impossible for us to save the globe. But on examination, what we found out was there is a small draining sinus over the superior orbit here. You can see that a small draining sinus in the upper lid. And when we did a CT scan, we found out a large abscess cavity over the superior orbit. And if you see here very closely, you can just find a small hyperdense area and a small hyperdense at the center. So which was projecting, which was just traversing through the orbit, and over the lateral orbit, you can find dense inflammation. So we just explored the orbit and we found out 2 different small streak of bamboo that was remaining within the orbit, and that had actually caused the inflammation to aggravate. And on appropriate treatment with antibiotics, with steroids, IVMP was given to patient, and this is after 1 month. The proptosis has reduced, but we could not decrease or we cannot regain the vision of this patient. So the importance is that whenever you have an wooden foreign body within the orbit, the wood tends to shatter over a period of time. The decompose and small shreds of foreign bodies can remain within the orbit. That needs to be carefully taken out by a thorough cupus irrigation. So I think the next controversial question is whether you should start antibiotics along with antifungals, or you should restrict yourself only to antibiotics and no steroids. So the literature in support of this is that the major studies which have been done in for wooden foreign bodies shows that the culture positivity is only in about positive in about 50% of the cases, and fungus is very, very rare. In such scenario, you have to take a clinical decision that after the initial microbiology culture comes out, and if it is negative, you have to start steroid to reduce the inflammation and to save the vision of the patient. Thank you.
Thank you, Samir, for so elaborately telling us the radiological findings as well as very useful case scenarios. Any question from the audience? Okay, we can close the session with, I think we have before time. Thank you.